Hi, this is Angela with Angela's Nurse Educator Toolbox. Today I'm going to lecture on OB complications. I have been an OB nurse since 1998, and I worked in New Orleans forever with lots of prenatal complications, OB emergencies in New Orleans. So I've had a lot of experience with OB complications. So we're going to go ahead and get started. The first one is hyperemesis gravidorum. This is a severe form of vomiting that persists past 20 weeks. Usually, women, when they're pregnant, will have nausea and vomiting the first trimester, so the first 12 weeks. But for this particular patient, it does not go away. It just gets worse. You'll see ketones in their urine. They're going to come in with signs and symptoms of dehydration, weight loss of more than 5% of their pre pregnancy weight. And they can't keep anything down. To diagnose it, you would check their urine for ketones, and if they start losing that much weight, more than 5%, they are diagnosed with hyperemesis gravidorum. To treat this is ondansetron, which is Zofran. They might use that to treat nausea and vomiting. Sometimes we use metoclopramide or Reglan to help stop the vomiting. Sometimes I've seen them put on a pump, an actual pump that they go home, a sub-Q pump of ondansetron to help with the nausea and vomiting. If it's really severe, they might be on total parental nutrition, peripheral parental nutrition. We're definitely going to give IV fluids to keep them from getting dehydrated. Sometimes taking vitamin B6 helps with that nausea. The problem we worry about, if they're throwing up this much and not able to keep anything down, they're going to start cramping, okay, and contracting, and can possibly lose the baby, the pregnancy. So we don't want that to happen. So we got to make sure they stay hydrated. An ectopic pregnancy, this occurs when the fertilized ovum implants outside of the uterus. Usually they'll have severe abdominal pain on one side. They'll have decreased blood pressure if it ruptures, increased heart rate, shoulder or neck pain. Sometimes they'll come in with vaginal spotting. This is diagnosed with an ultrasound, usually in the first trimester. Also monitoring beta HCG levels. That's your blood test for pregnancy hormone. They'll see if it's increasing or decreasing, and if they do not see a gestational sac in the uterus, that's usually a sign that it could be a possible ectopic pregnancy. They are not easily able to be seen right away. You really have to be looking for it, and an experienced sonographer that would be really looking for an ectopic pregnancy. To treat this, they would prefer to give you methotrexate. This is a chemotherapy drug that they use, which would cause the baby to get reabsorbed in the fallopian tube. They can give this as long as it's not ready to rupture. If it ruptures, they might have to do a salpingostomy, where they remove the fallopian tube or part of the fallopian tube. The problem with that, it would affect their fertility later on in life. If they did remove a part of it where the baby was, it would have scar tissue and more likely reoccur, more chance of having an ectopic pregnancy in the future. Gestational diabetes. This occurs when the blood glucose is elevated in a pregnant female that was not previously diagnosed with diabetes beforehand. Signs and symptoms: increased thirst, hunger, and urination. They can get frequent UTIs, yeast infections, fatigue. This one's usually diagnosed with a glucose tolerance test between 24 and 28 weeks. To treat it, it could either be diet controlled, or mom might actually have to take insulin throughout her pregnancy for the rest of the pregnancy. We want to make sure it is controlled, because if mom continues to have high blood sugars, this can impact the baby, and the baby would be an LGA, large for gestational age, so a very big macrosomic baby. which may be impossible for mom to pass vaginally, which can lead to birth trauma for both mom and the baby. The next one is an incompetent cervix. This is the inability of the cervix to retain a pregnancy, usually in the second trimester, and this is without the with the absence of contraction. So she's not contracting. It's just her cervix can't stay closed. And in this little picture right here, I have a image of the cervix where it's starting to open up. Signs and symptoms: pelvic pressure, back pain, cramping, dilation of the cervix. Mom might actually have funneling of her water bag through the cervix. Okay. To diagnosis, they can measure cervical length on the ultrasound. Mom might have a history of preterm births in the second trimester. Usually, it's diagnosed after repetitive loss in the second trimester. So if she's had a pregnancy that she's lost before because she just went into labor because her cervix was opening early, they would diagnose her with incompetent cervix. To treat this, they can do what's called a cerclage between 12 to 14 weeks gestation, where they're going to go and actually suture the opening of the cervix closed just to reinforce it. So hopefully it can withstand the pressure of a baby and the building weight of the baby in the uterus and not prematurely open and dilate. And also pelvic rest of all sorts. So that means no sex, no stimulation down there. Usually they don't do any vaginal exams. They don't want to stir anything up. If mom gets to about 35, 36 weeks with a cerclage, they will go in and remove the stitch so that she can deliver safely because they got her to the end of the pregnancy. Placenta previa. This is a condition in which the placenta implants low or near the cervix. Okay, so it can be either one. Signs and symptoms are painless, bright red bleeding. It's usually in the second trimester. So nothing's hurting. She just starts bleeding. To diagnose it, they can see it on ultrasound where they can see the actual presentation of the placenta. To treat this would also be pelvic rest, no vaginal exams. If mom's in the hospital, if she has a complete previa, I mean the whole placenta is right over the opening, that we might end up doing type in screens because she will need blood transfusions more than likely. And we would do a C-section for delivery. The problem with that placenta right there, it aggravates the cervix, the weight of it sitting there. So if mom starts to contract prematurely, the contractions can trigger the bleeding from the placenta. And we would definitely be monitoring that baby and monitoring mom's H&H. A placental abruption. This is a condition in which the placenta prematurely separates from the wall of the uterus. It could be partial, complete, or occult. Occult means hidden. Signs and symptoms. This is usually port-colored wine. Okay, so a port is a type of wine, dark red wine. Bleeding, tender abdomen, fetal distress when we look at the baby on the monitor. To diagnosis, they could diagnose this with ultrasound and based on signs and symptoms, and they can also do labs on mom. To treat it, we would monitor fetal monitoring if it was incomplete or partial abruption, because we really want to try to get that baby to stay in mom's uterus as long as possible so it can be fully developed and not have issues with preterm birth. So fetal monitoring, as long as the baby's doing okay with a partial abruption, we can let the baby stay in there. With an occult, we don't see any outward bleeding. It's all internal, and mom would really have that board-like abdomen, very tender abdomen, and fetal distress. We'd also give mom oxygen. We'd be monitoring vital signs. We'd monitor her bleeding, even if it's the partial. We've done that for a while when I was in New Orleans. IV fluids, possibly give blood transfusions, and we would do a C-section for the delivery. The next condition is placenta accreta. This is a condition where the placenta villi are attached too deeply into the wall, causing complications with removal. So they have kind of grown into the wall of the uterus instead of just attached to it. So just kind of think like if you had a vine, an invasive vine, you plant that in your yard and it just goes crazy and it's everywhere and you keep trying to pull up roots. That's the same kind of thing. It's just really grown all over the place. Signs and symptoms, it's inability to easily deliver the placenta after delivery. So the placenta doesn't release it, and mom continues to bleed. So that is the big problem with an accreta. With that placenta still in after delivery, her uterus cannot clamp down and become hard like a softball when we do fundal massage because of this glob of tissue that remains. So the blood vessels stay exposed and open and she can hemorrhage. So to treat this, we can give it Pitocin. We usually do it wide open in the IV fluids. Methergin to treat the bleeding, hemabate. We might have to manually remove the placenta, where the doctor, if it was vaginal, might reach up in there to actually remove pieces of the placenta, or we actually may have to do a total emergency hysterectomy, okay, to save mom's life. Preterm labor. This is when you have contractions greater than 6 an hour before 37 weeks gestation that cause cervical change. Some people can have contractions and it's just preterm contractions. Preterm labor is if it causes cervical change. So you start to dilate or efface. To diagnose this, so say I come into the hospital and I've been having some contractions. They can do a swab test, a fetal fibronectin test, to determine whether or not I'm more than likely to go into labor in the next 48 to 72 hours. We do fetal monitoring and SVEs, sterile vag exams. We can measure cervical length on the ultrasound to see if it's getting shorter, it's becoming more effaced, or if she's dilated. To treat this, they might give nifedipine by mouth, Indocin by mouth. We can give magnesium sulfate IV. Okay, so that would be in IV fluids, IV piggyback. We're trying to relax the smooth muscles of the uterus to stop contracting. We would give betamethasone IM to mom. So this is going to help stimulate the lung development in the baby, letting the baby know, hey, you're about ready to get evicted. So you better hurry up and get those lungs ready because you're getting ready to come out. So we really try to get those steroids in for the benefit of the baby. Sometimes we'll use progesterone IM. That also helps with preterm. But they found we started doing that if you had first trimester bleeding, giving some progesterone shots, or if you had multiple babies, the pregnancy lasted longer and was less likely to succumb to preterm labor. PIH, this is pregnancy-induced hypertension. You might have heard the word preeclampsia. Those are used interchangeably. Symptoms of PIH, the mom did not have high blood pressure before. She might complain of a headache, like the worst headache in her entire life. If any pregnant patient ever comes in telling you that, get a blood pressure immediately. She might complain of having blurry vision, seeing floaters or spots in her vision. Epigastric pain up where the liver is, okay, because the liver would be distended. She'd have proteinuria in her urine, weight gain, edema. Usually they are swelling, especially ask about that in the feet. It's the hands. Their face might actually be swollen. And they'll have elevated blood pressures greater than 140/90. So that's our PIH or preeclampsia. To diagnose it, we'll do serial blood pressures. They may do a BPP on the baby to see how the baby's tolerating it. A 24-hour urine will collect and check for protein and creatinine clearance, and also monitor mom's liver function test. To treat it, mom might just need to be on an oral blood pressure medicine like nifedipine, hydralazine, or labetalol. Sometimes we might have to give hydralazine or labetalol IV push to get it down if the blood pressures are super high. We'll do magnesium sulfate in an IV drip for severe cases. So these are really high blood pressures. We want it to prevent mom from having a seizure because that's what can happen when her blood pressures get super high. So that would be eclampsia if she actually has a seizure. So we're putting her on a mag sulfate drip to prevent mom from having a seizure. And sometimes we might just have to deliver the baby. A lot of times, if she's got really high blood pressures, the baby will suffer with IUGR, which is intrauterine growth restriction. So this baby stops growing at a certain point because it's not getting the oxygen it needs because of these high blood pressures. HELLP syndrome, this stands for the H is hemolysis of your red blood cells, the EL is elevated liver enzymes, and the P is low platelet count. So low platelets, less than 100,000. This can develop as a result of, as a complication of preeclampsia or eclampsia, so that high blood pressure. She would complain of severe upper right quadrant pain. She'll have elevated liver enzymes, may even be jaundice, having bleeding and clotting problems. To diagnose it, labs. They're going to do labs. She'll have a super low platelet count, usually less than 100,000. I've seen really low. I've seen the lowest was like 20,000 in a patient that had HELLP, and elevated liver function tests. To treat this, we definitely have to administer platelets and blood products. We would definitely deliver the baby. Mom has a mortality rate of 25%. They definitely would give her oxygen because of that hemolysis of red blood cells. She may be very short of breath, tachypnic, and tachycardic. Last one is postpartum hemorrhage. There are four causes. It's called the four T's: tone issues, trauma, tissue, or thrombin. So postpartum hemorrhage can occur. Signs and symptoms would be a boggy uterus. So after the baby is born, we are to massage, do fundal massage of mom's fundus, which is the top part of her uterus, to get it to become very firm and tight, where it's like a tight softball that you would palpate in her lower abdomen area. We want it to stay that way. If it's boggy, that means I really can't feel that uterus. So there's no tone there. If it's not clamped down, she'll bleed and have hemorrhaging. So she will also have excessive vag bleeding, decreased H&H. The blood pressure will start to drop on mom. She'll have an elevated heart rate because her body's trying to compensate for this blood loss. So tone atony, it's called uterine atony, is the number one cause of postpartum hemorrhage. That's why we want moms to breastfeed right after delivery, because that will stimulate their uterus to clamp down. Sometimes tone can be affected by a full bladder. If your bladder's filling up after a delivery, your uterus doesn't have room to clamp down. It gets displaced off to the left usually and higher than the level of the umbilicus. So we want to make sure mom can void, because that might help. We might have to put in a Foley catheter to drain that bladder, because that can lead to uterine atony and postpartum hemorrhage. Trauma, this can happen due to forceps that they might use during the delivery. It could happen with a placental abruption that mom might have had. Those kind of things that could have triggered this postpartum hemorrhage. Tissue, this is where you might have retained placental fragments. For example, with placenta accreta, I might have pieces of that placenta. A lot of times with our preterm deliveries, that placenta wasn't ready, it wasn't fully cooked to let go of the uterus, and those tend to stay retained, and we might actually have to go in and surgically remove it or manually remove the pieces of placenta that might be left in. And thrombin, this is any bleeding disorder mom might have, like von Willebrand's can affect it. If mom had HELLP syndrome, DIC, any of those things can be triggering postpartum hemorrhage. So diagnose it, it would be a blood loss of greater than 500 with a vaginal birth, and diagnose 1,000 milliliters or more blood loss with a C-section. To treat it, we definitely first start with that fundal massage, trying to get that uterus to firm up and clamp down to close off those exposed blood vessels. We give Pitocin in their IV fluids wide open on the pump, just getting it in there as quick as possible because Pitocin causes contractions. We might do Cytotec, and we usually might do this rectally because if you stick it in the vagina and she's hemorrhaging, it's coming right back out. So a lot of times we will I've done like 800 micrograms of Cytotec up the rectum to control postpartum hemorrhage. They may give mom Methergin to help with the bleeding or Hemabate to stop bleeding. And they have come out with something, it's a Bakri, it's a uterine balloon. It's almost like a Foley catheter, but they put it into the uterus and inflate this balloon to put pressure up against the blood vessels that are exposed to hopefully give time for mom to start to clot so we don't have to do an emergency C-section, because that's something we don't want to have to, not a C-section, emergency hysterectomy, because that's something we don't want to have to do because that can affect her fertility. Okay. Mortality rate for postpartum hemorrhage is 25%. We'd also put her on oxygen. Well, I hope this lecture helps about OB complications. I will be posting more lectures and recordings on different topics. If you like these, like and subscribe to my YouTube channel. Have a great day.